Afternoon, and welcome to the American Heart Association's Moderate Aortic Stenosis Virtual Grand Round Series. We're thrilled to have you with us today for our second session, Identifying the Right Patient, Echo, Risk, and Readiness. Before we begin, a few quick housekeeping notes. Today's webinar is being recorded, and all participants have been muted upon entry to reduce background noise. We encourage an open, conversational discussion, so please engage and share your thoughts. Time has been dedicated at the end of today's session for Q&A. Please feel free to submit your questions via the chat at any time throughout the didactic sessions. We will address as many questions as time allows during the dedicated Q&A portion of today's session. A recording of this session will be available in the coming weeks as an enduring educational resource on www.heart.org. My name is Anar Valyani, and I serve as a Program Implementation Manager in Clinical Studies here at the American Heart Association, overseeing our work in moderate aortic stenosis. I would like to take a moment to extend a special thank you to Cardigan Inc. for being a proud supporter of the American Heart Association's Heart Valve Initiative. It's now my pleasure to introduce today's expert speakers. Dr. Anita Kelsey is a professor of medicine at Duke University Health System, Vice Chief of Academic Affairs and Operations for Cardiology, Medical Director of the Duke Cardiac Ultrasound Certificate Program, and a nationally recognized expert in structural heart disease. Her work focuses on the clinical assessment, risk stratification, and longitudinal management of patients with aortic stenosis, including the interpretation of echocardiographic data and integration of clinical workflows to support timely referral, disease management, and clinical trial readiness. Alexandra Vinson is the lead cardiac sonographer for the structural heart program at Stanford Healthcare. She brings deep expertise in advanced echocardiographic assessment of aortic valve disease, including the evaluation of borderline and discordant findings, and plays a central role in leveraging echo and EMR data to identify appropriate patients for structural heart interventions and research participation. We're honored to have you both with us here today. Please note, the recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. These materials are for educational purposes only and do not constitute an endorsement or instruction by the Heart Association. The American Heart Association does not endorse any product or device. Disclosures for Dr. Kelsey and Lexi have been listed here as well. Today's session will begin with an in-depth look at the key echocardiographic parameters used to assess moderate aortic stenosis, along with practical opportunities to integrate echo data into existing EMR workflows. We'll then explore hemodynamic principles in aortic stenosis evaluation and review strategies for resolving discordant findings. The session will conclude with two case-based discussions that bring these concepts together in real-world clinical scenarios, followed by a moderated Q&A discussion. With that, I would like to turn the mic over to Lexi, who will help kick things off today. Welcome, Lexi.
Thank you so much, Inara. And I just want to say a thank you to the American Heart Association for the honor of speaking, and a special thank you to Dr. Kelsey, who's been wonderful to partner with on this virtual Grand Round session. Why focus on moderate AS? Moderate aortic stenosis is under-recognized and undertreated. It often falls into a gray zone, not severe enough to trigger intervention and not mild enough to ignore. As a result, symptoms may be attributed to comorbidities such as HFpEF, lung disease, or simply aging. This leads to delayed diagnosis of progression and missed opportunities for timely care. Moderate AS is often considered watch and wait, but this assumes that patients remain stable until they meet criteria for severe disease. In reality, many patients develop functional limitations, reduced exercise tolerance, and early heart failure symptoms before reaching severe AS by the numbers. Progression risk varies widely across patients. Moderate aortic stenosis is not a uniform disease. Some patients progress slowly over many years. Others demonstrate rapid hemodynamic progression and clinical decline. There is an increasing evidence of heart failure symptoms despite their moderate classification, and valve gradient alone may underestimate the physiologic burden of the disease. We now have an opportunity to intervene earlier. Ongoing trials are directly challenging the traditional paradigms such as Catalyst AB and the Progress trial. These studies are evaluating whether earlier intervention can improve symptoms and prevent irreversible myocardial damage. How do we define moderate aortic stenosis? For moderate aortic stenosis is defined on echo by three parameters: an aortic valve area of 1.0 to 1.5 centimeters squared, a mean pressure gradient of 20 millimeters of mercury to 39 millimeters of mercury, and a peak velocity of 2.5 meters per second up to 3.9 meters per second. This slide shows the parasternal short axis of the aortic valve on echo, ranging from normal to severe, showing how over time the aortic leaflets become thickened, calcified, and restricted with their opening. What constitutes a good echo? So I sit in a valve clinic at Stanford, and I am often asked, is this a good echo when receiving echo reports from outside facilities or even internally? So what is a good echo? A good echo will have measurement accuracy. There are three key measurements in AS patients which need to be accurate to put out good data and give the proper diagnosis, which we're going to go through in the next few slides. A good echo is going to assess the flow state with either LVEF and or stroke volume index. Low flows can mask severe AS, or it can make moderate aortic stenosis look less significant. A good echo has accurate CW Doppler beam alignment parallel to flow. Even a small misalignment can cause significant underestimation of a gradient or velocity. A good echo is going to interrogate multiple views to get gradients, not just one window. Sonographer variability. Unlike many imaging modalities, echo is not passive imaging. It requires active probe positioning, intentional window selection, and real-time optimization. Two sonographers scanning the same patient can produce different velocities and gradients, leading to different AS severity classifications. Patient positioning and acoustic window are very important in echo. Patients will ideally be able to lie on their left and right side. Small rib spaces, body habitus, and lung disease are just some considerations that may affect the quality of the imaging window. There are three key measurements on echo needed to determine the severity of the aortic stenosis, and these measurements are our LVOT diameter, our pulse wave Doppler, which is the velocity right before the aortic valve, and then our continuous wave Doppler, which is the velocity going through the aortic valve. And these are used in the continuity equation, which very simply is a formula based on the principle what flows in must flow out. Essentially, if the velocity increases, the valve area must decrease. A higher velocity across the valve equals a smaller valve area. And this equation is what gives us our aortic valve area. For many research trials, aortic valve area often drives trial eligibility, but we must validate this information. The first measurement, the LVOT diameter measurement, is taken in the parasternal long axis and is literally measuring down to the millimeter. Small differences such as suboptimal window or a wrong timing in the cardiac cycle can lead to larger errors. Because this measurement is squared in the continuity equation, a small LVOT measurement error can lead to a larger aortic valve area calculation error. For our velocity before the valve, the pulse wave Doppler, this is a tricky measurement to get. The heart is moving, the patient is breathing. Too close to the aortic valve will contaminate the signal with a higher flow velocity, leading to an overestimation of the aortic valve area, undercalling the severity. And too far away will equate to lower velocities, which underestimates the aortic valve area and will overcall the severity. For continuous wave Doppler, different angles through the valve can give us different velocities. These images show three different windows, an apical 5 chamber, an apical 3 chamber, and the right sternal border, all on the same patient, all with different gradients. When training fellows or new sonographers, I often ask what angle is the best angle to obtain the highest transaortic velocity. And this is a trick question because the answer is whichever angle you can get the highest gradient. With these calcified aortic leaflets, which are thick and restricted and have fixed leaflet motion, you can get very eccentric jets. So the sonographer needs enough time to assess all the different angles of flow through the aortic valve. A less experienced sonographer or time-limited scan may undercall the severity of the aortic stenosis, and other considerations are workflow and time constraints. High-volume echo labs or doctor's offices may skip non-standard imaging windows, such as a suprasternal notch or a right sternal border, and accept adequate instead of optimal signals. Other considerations in determining what a good echo is are to make sure the gradients are not overtraced, they're not measured solely after a PVC, and taking into consideration arrhythmias such as AFib, where current guidelines say to average 5 beats. On our echo report, key reporting metrics as defined by the AHA as part of Target AS are to have in the summary section of the echo report the aortic valve area, the mean pressure gradient, the peak velocity, LVEF, and a clear definition of the severity of aortic stenosis. This is an example of our interpretation summary at Stanford, where we try to answer the indication for the echo in the first line and include all Target AS metrics. Additional metrics are either added to the summary section if pertinent to the patient's echo and can also be found in the numbers section at the bottom of the echo report. While the numbers section on any echo report can be quite busy as there are no shortage of things to measure on echo, I want to highlight the aortic values section on our echo report and pay close attention with our moderate AS patients to the stroke volume index. So discordant AS measurements is a common problem. Moderate aortic stenosis often sits in a discordant zone, especially with low flow states, LV dysfunction, small body size. And these cases may require additional parameters such as stroke volume index, dimensionless index, or additional imaging such as CT calcium scoring to truly assess the severity of the aortic stenosis. Discordance between clinical presentation and the imaging is a signal for further investigation, not just noise. And what is the best way to evaluate discordant numbers? We need to have a stepwise evaluation of discordant AS. And the first thing we need to do is confirm our measurement accuracy. For the LVOT diameter, do we have the same measurement over serial echoes? For Doppler alignment, do our Doppler signals look good? A reliable continuous wave Doppler tracing should have a dense, well-defined spectral envelope. It should have a clear peak velocity. It should have minimal signal dropout. And we should avoid faint or incomplete Doppler envelopes or overgained or overtraced signals. Second, we need to assess our flow state. Do we have a low stroke volume index? Are we less than 35 milliliters per meter squared? Is our ejection fraction reduced? Are we below 50%? Step 3, do we need additional testing then? Do we need a CT for aortic valve calcium scoring? Do we need to consider a dobutamine stress echo? And step 4 is clinical context. What are the patient's symptoms? What is the patient's heart failure status? So moving into EMR-driven workflows. Why AI? We have a clinical problem with an unmet need. Moderate aortic stenosis represents a heterogeneous population. Some patients remain stable over the years and others progress rapidly with early clinical decline. Traditional follow-up strategies treat all moderate aortic stenosis the same, and AI can identify patterns of progression and stratify risk at an individual level. Patients with moderate aortic stenosis often attribute dyspnea and fatigue to just aging or comorbidities. They're labeled as HFpEF or deconditioned, and this can lead to clinical underrecognition of true valve-related symptoms. Discordant echo measurements. Moderate aortic stenosis is where measurement variability lives. Gradient, velocity, and aortic valve area may not align. Sonographer variability and flow state can complicate the interpretation, creating diagnostic ambiguity and delayed decision making. AI can monitor patients and identify disease trajectory and prompt earlier referral aligned with moderate AS trials such as Catalyst AB and Progress. AI can help surface high-risk patients by combining echo with EMR data and longitudinal trends. Moderate aortic stenosis is not a diagnosis, it is a spectrum, and AI is needed to uncover the high-risk patients hidden within. So why is echo alone not enough? Echo severity metrics are essential, but they're incomplete. There is measurement variability, there are discordant values and low flow states, and the LVEF may remain preserved while myocardial dysfunction progresses. Very simply, valve severity does not equal patient risk. AI-enabled systems can link echo parameters with symptoms, hospitalizations, medications, instead of over-reliance on an aortic valve area alone or discordant echo values. In some instances, an aortic valve area will not even be in the final echo report if the AS is only classified as mild to moderate. Integrating echo and EMR data removes echo interpretation and isolation, and instead of follow-up intervals based on broad guidelines, AI can individualize patient follow-up intervals. Bridging echo and EMR data is how we recognize earlier disease impact and reduce delays in care. If we are able to bridge the gap between echo data and EMR data, we can filter large volumes of patients more efficiently. Where echo data is purely numbers driven, EMR and clinical data can integrate many other variables to give a complete clinical picture. AI can help by integrating longitudinal EMR data, detect subtle changes in functional status, and flag patients whose clinical trajectory doesn't match moderate disease. AI can help users with discordant echo numbers and flag potential patients with underestimated AS severity, shown in these three examples, where the AVA is discordant from the patient's defined severity on the echo report. Last month at Stanford, I was tasked to pull all of our patients within the last 18 months with a diagnosis of moderate aortic stenosis or more. We wanted to do a comparison between our echo database and our echo integrated AI system to drive reach out to our network providers. Both of our echo database and our echo AI system queried the same amount of patients, 2,154, but this is where we ended with our echo database query. Integrating our Echo AI system, I was able to filter out disease and palliative patients, dropping the number to under 2,000, and then able to further remove treated patients for both SAVR and TAVR, leaving us with a much more tangible number of 882 potential untreated patients. We kept our search broad for our moderate aortic stenosis query, but when using AI for clinical trial enrollment, there's additional query features of renal function, symptoms, heart failure admissions, NYHA class that have all been key in finding appropriate patients more efficiently. We have taken this list and filtered again using our AI system by a patient's managing provider. And this has provided visibility to see providers that had higher numbers of moderate or greater aortic stenosis patients and begin our focus there. Since implementing the use of an echo alert system at our facility, we have found that trial availability is a great icebreaker for reach out. It's very hard for all the providers in our network to know what trials are available to what patients and at what time. So prior to reach out, we collaborate with our dedicated research trial coordinators and make sure that the patient is appropriate. And this way, the patient has already been screened in when providers discuss potential trial enrollment with their patients. We also found that we needed to shift our focus to our primary care physician group, as we were missing the opportunity to identify these patients earlier and not wait for severe AS by echo alone. And additionally, we are working on including recommendations in our echo report for referral to our valve clinic, and we are also discussing including potential recommendations to the patient. Moderate AS is not benign. It is a dynamic, heterogeneous disease where symptoms, myocardial damage, and risk often precede severe classification. AI is a co-pilot, not an autopilot. We talk in our clinic a lot about the human element in AI. AI can aid recognizing the right patient at the right time, and it helps to open the door to earlier potential disease modifying intervention, but we need the human element or manpower behind the AI as well. Moderate AS requires integrated interpretation. The problem is not a lack of data, it's a lack of connection. And bridging echo and EMR transforms isolated measurements into meaningful clinical insight, revealing high-risk patients hidden within the moderate AS population. And I wanted to end this portion by letting you all know I used AI to create this picture.
Hey, Lexi. Next, we welcome Dr. Anita Kelsey, who will be discussing what influences echocardiographic assessments and how to resolve discordant findings. The floor is yours, Dr. Kelsey.
Thank you so much, Inara and the American Heart for inviting me to speak today. And Lexi, it is wonderful working with you. It's really been great to get to know you as we prepare these talks today. So, today I'm going to talk to you a little about the hemodynamics of the patient and the physics of ultrasound and how they affect our assessment of aortic stenosis by echocardiography. I also want to talk a little about the value added using additional imaging when we have discordant echocardiographic findings. First, we have to look at the principles of flow. We'll start with the Bernoulli principle. It's based on the law of conservation of energy. We understand that flow through the heart is the same in any place. It's a closed system. And blood moving through narrower areas will be moving at higher velocity. And as the velocity increases, the pressure decreases. And we'll be able to measure that pressure drop, like Lexi was discussing, with our continuity equation. We can think of flow through the heart just like flow from a hose, here shown at the backyard of the Weiss household. On the left, you'll see that flow velocities are low, and we let the hose just trickle, the water trickle from the hose. On the right, when you're too lazy to want to water the plants on the other side, you'll put your thumb over the hole and make the hole smaller, and flow velocity will increase. Both have the same volume of flow at the house, the water coming into the hose, but looking at the velocity and the change in pressure allows us to understand and calculate the aortic valve area. And Lexi showed you those calculations for aortic valve area based on LVOT area and the 2 Doppler measurements. So how do we use that to manage our patient with aortic stenosis? We use these measurements to understand the severity of stenosis. Calcific aortic stenosis is a chronic progressive disease among older adults. Here on the left, those that are at risk for aortic stenosis, and you know the group on the far right that have severe symptomatic aortic stenosis are in need of intervention with our multidisciplinary teams. Today, we're going to focus on the group in between that have the progressive calcific aortic stenosis, more in the moderate range. And these patients need regular surveillance, and we need to identify them on our echocardiograms. And Lexi told you these numbers as well. First, focus on the right. Severe aortic stenosis has a valve velocity of greater than 4 meters per second, a mean gradient greater than 40, and an aortic valve area less than 1. But this group in the middle has the finger halfway over the hose, making the velocities a little bit higher than they would have been otherwise, with a peak velocity 3 to 4, mean gradients 20 to 40, and aortic valve area 1.0 to 1.5 centimeters squared. And these patients should be followed by a clinician with a repeat echo every 1 to 2 years. But there are some pitfalls in our echocardiographic assessment, and Lexi mentioned some of those. Sometimes things like afterload can also affect our measurements, as well as changes in flow from the house. If you turn the dial up high, you'll get a higher flow or a lower flow if you drop it down. Concomitant diseases can also confound our interpretation of the severity of AS on echocardiography, and we're going to go through the physics of ultrasound of these changes. So first, let's talk about afterload. So blood pressure elevations can decrease the flow velocity that we measure on Doppler echo, underestimating the severity of aortic stenosis. So here is shown the same patient, continuous wave Doppler measured through the aortic valve from left to right, higher blood pressure to lower blood pressure. And this patient was administered isosorbide dinitrate to lower the blood pressure. As you go across from left to right, you'll see that the velocity through the valve increases as the blood pressure decreases. And we know that we should be doing our echocardiograms when the systolic blood pressure is less than 140. The 2020 American College of Cardiology and American Heart Valve Guidelines tell us that if there's only moderate stenosis when you do your echocardiogram and the patient is hypertensive, they should be reassessed after their blood pressure is controlled with repeat echocardiographic measures to accurately assess the severity of aortic stenosis. Another thing that affects the flow is the flow at the house going into the hose. This is a graph of, on the x-axis, the transvalvular flow in milliliters per second. And on the y-axis, the mean transvalvular gradient for the aortic valve. You'll notice three curves. The top curve in blue is those with an aortic valve area of 0.7 centimeters squared. The middle curve in red has an aortic valve area of 1.0 centimeters squared. And the curve in green has an aortic valve area of 1.5 centimeters squared. The problem with low flow, low gradient AS, as shown by the small dotted line at 125 milliliters per second, is that all three aortic valve areas all have a mean gradient less than 20. You wouldn't be able to distinguish these three valves in any way in that low flow state. But if you move the flow to 250 or normal flow, all three valve areas are distinctly different, their gradients are different, and they're easy to differentiate. And as a reminder, the low flow states include reduced EF, but they can also include small hypertrophied ventricles or patients with significant mitral regurgitation, where the flow is going back into the left atrium and not out the aortic valve. High flow states include things like anemia, fever, hyperthyroidism, anxiety, people in pain, or with significant aortic regurgitation. Also, people who have high flow states from things like AV fistulas can have increased flow across the valve. So how do we tell those apart by echo? Well, Lexi mentioned that critically important number, the stroke volume index. And if it's less than 35 milliliters per beat per meter squared, we know it's a low flow state. So how do we sort out the high flow states? That happens when we get discordant measures where the gradients are very high, the velocities are very high, but the aortic valve area is not appropriately low. So gradients that might be consistent with a severe aortic stenosis, a velocity greater than 4, mean greater than 40, but aortic valve area that's not less than 1.0. That would be a high flow state. How about concomitant disease? So our patients with hypertrophic obstructive cardiomyopathy have obstruction right below the valve. That can confound our Doppler interpretation of aortic stenosis and make us overestimate the severity of stenosis. When you think about the hose again, if you crimp down the hose in the middle, the velocity coming out the end of the hose will be a higher velocity, even though the opening of the hose has not changed. You haven't put your thumb over the top of the hose, or you haven't reduced your aortic valve area, and you'll still see a higher velocity. And Lexi mentioned this too, but I just want to remind you, this is critically important. And when you're looking at an echo report, you can't tell how it was performed, but a well-performed echocardiogram for aortic stenosis will look in 3 different windows. Here shown the right parasternal, the suprasternal, and the apical if you go around clockwise. And as Lexi showed you, you're going to get very different Dopplers through those 3 locations, with the highest Doppler being the most accurate, the most parallel to flow. And that's a basic principle of Doppler. So when do we use other modalities? First, this is a comparison of imaging modalities for one patient looked at in A with an echocardiogram in 2D, B with CT calcium scoring, C with CT angiography, and D with PET CT. And on echocardiography, we can't tell the difference between brightening of the image, the white spots, whether or not they're from thickening of the valve or calcification, unless there's shadowing. So we are limited in our ability to understand the amount of calcification on the valve by echo alone, and we certainly can't quantify it. But CT scan allows us to both quantify the amount of calcification and show where it's located. So it helps us differentiate how severe the stenosis is. The LVOT measurement that Lexi had mentioned, it's done as a linear measurement on our transthoracic echocardiogram as shown in image B. And it can be incorrect if the area is not circular, if it happens to be oval. And we can use a hybrid approach to estimation of aortic valve area by looking on the same patient at their CT scan and directly planimetering the LVOT area and incorporating it into our measurements for aortic valve area by echocardiography. And this just shows us the progression of aortic stenosis from a healthy patient on the left to severe patient with severe AS on the right, showing the changes that happen with calcification on the CT scan by both CT calcium scoring, 3D calcium, and then our last 2 with our parasternal long axis, not showing us calcification, but reduced leaflet motion and thickening, and Doppler showing us the increasing gradients over time. And for those patients with reduced ejection fraction and low flow, we're able to move them on the curve from the left where I showed you earlier that they have a stroke volume index that is reduced. By giving them a small amount of dobutamine will increase their stroke volume more than 20%, be able to differentiate how severe the stenosis is. That's very helpful when the ejection fraction and the flow are reduced, but in patients who have low flow state because of a hypertrophied small ventricle, it might be helpful in those normal EF patients instead to look at quantification of the calcium score. And this is a demonstration of doing the calcium scoring for patients, noticing that men have a higher burden of calcium at the same severity of stenosis than women. And then we always want to keep in mind that it's important to recognize patients with moderate aortic stenosis and treat them appropriately, but hopefully enroll them in clinical trials that will help us better understand. We're involved in the Catalyst AV trial, which is a 2-part phase 2b/3 randomized double-blind clinical trial that looks at the effect of Atigawa on slowing the progression of aortic valve calcification. It'll also look at how does changes in the aortic valve calcium result in changes in the echocardiographic measurements of aortic stenosis severity as well as diastolic function, and how these changes relate to symptoms and cardiac function when people perform cardiopulmonary stress tests. This trial is currently enrolling, And if you look in the bottom left here, the key study inclusion criteria include patients older than the age of 50 with moderate calcific aortic valve stenosis. They have aortic valve areas in that moderate range between 1 and 1.5. Their aortic valve calcium on CT scan is between 600 and 1200 Angston units for women and 600 and 2000 Angston units for men. And their LVF is greater than 45% at the time of the screening, and they don't have any contraindications to doing a stress test walking on a treadmill for us.
Thank you,
And
Dr.
now let's
Kelsey.
do some cases.
Perfect. We'll start off with Lexi, who will start our case-based discussion with the presentation of patient case number 1.
Thank you. My case study is about an 81-year-old female who has a history of hypertension, hyperlipidemia, GERD, gout, and a hiatal hernia. Her chief complaint was ongoing dyspnea on exertion over the last 2 years, and she endorsed bed apnea. She had difficulty carrying her groceries, difficulty with one flight of stairs in her house, all of which she was previously able to do. She has generalized fatigue, she had occasional dizziness, and she is admittedly more sedentary over the last year. We have her echo images in our system from a 2017 emergency room visit for chest pain, which I wanted to show because at this time her valve has a bit of calcium, but overall opening well. And then for the echo images in 2021, at this time she was referred to our TAVR clinic for her progressive dyspnea on exertion times 2 years. Her transthoracic echo showed moderate aortic stenosis. She had a mean gradient of 22 millimeters of mercury and an AVA of 1.3 centimeters squared with preserved LV function, and she had elevated left-sided filling pressures. Her CTA showed no significant coronary artery disease, so she was scheduled for follow-up in our valve clinic and also referred to our heart failure clinic for management of her diastolic dysfunction. In 2022, our patient initially had some mild improvement after her hernia surgery with routine activities, but she was still experiencing reduced exercise tolerance and fatigue, and she felt she was overall slowing down. In 2023, the patient returned to clinic expressing that she was still struggling to try to improve her exertional capacity. She still had dyspnea with hills or on the stairs at her house, and she also had experienced now a few episodes of lightheadedness. Her mean gradient had increased to 29 millimeters of mercury at this time with an AVA of 1.0 and a dimensionless index of 0.28. Due to her symptoms, the patient was then enrolled into the PROGRESS trial, and she was randomized to the clinical surveillance arm. Visually, her valve is more calcified and has more restriction with her leaflet excursion. In August of 2024, the patient was again evaluated in our valve clinic where it was noted that her AS had progressed into this moderately severe range. Her mean gradient was 35, but her aortic valve area was now less than 1 at 0.8 centimeters squared. And at this time, when meeting with our valve clinic APP, they discussed watchful waiting versus TAVR SAVR, to which the patient wanted to discuss her results and her options with her family. However, just 2 months later, in October of 2024, the patient had even more increased shortness of breath and fatigue, and she asked to be reevaluated sooner in our valve clinic. On her repeat echo in October, at this time, she showed severe AS with a mean gradient of 41 millimeters of mercury and an aortic valve area of only 0.5 centimeters squared. On December 6th, the patient crossed over to treatment and she received a TAVR. What this timeline really highlights is the disconnect we often see between disease severity by echo and the patient's clinical trajectory. If we start in 2021, this patient clearly falls into the moderate AS range, mean gradient of 22, an AVA of 1.3, and over the next 2 years, we see what looks like expected gradual progression, nothing that immediately triggers intervention based on guidelines. But in 2023, something important is happening. Even though the echo is still categorizing this as borderline moderate to severe AS with a mean gradient of 29 and an ABA of 1.0, the patient's velocity is rising, and more importantly, the patient is experiencing significant symptoms of her AS. Yet by strict echo criteria, this patient has not officially reached severe AS. In early 2024, the patient is enrolled in the PROGRESS trial and randomized to clinical surveillance, which reflects our current paradigm. We wait until the numbers cross the threshold, but the disease doesn't often wait. In October of 2024, we finally see clear severe AS by echo. The gradient has risen from 35 to 41, and our aortic valve area has dropped from 0.8 to now 0.5. Her velocity is now exceeding 4 meters per second, and not surprisingly, this patient by this point has become overtly symptomatic and has now required urgent intervention. Ultimately, by December, the patient undergoes TAVR. The timeline of her journey shows that this patient's symptoms preceded her severe aortic stenosis echo diagnosis, with evidence of myocardial damage and increased left-sided pressures beginning as early as 2021. This case reinforces that symptoms are not late findings. They can be an early signal that the ventricle is already under stress, even when the numbers haven't crossed the threshold. In her instance, the patient worsened before they became quote unquote severe. And moderate aortic stenosis can be clinically significant before it appears severe on echo. Symptoms should not be dismissed when echo parameters suggest only moderate disease. Symptom onset may outpace echocardiographic progression, and the patient really declares the severity before the echo does. Opportunities for moderate AS research trials shift care from reactive to proactive. Trial enrollment allows for patients to have access to care before irreversible myocardial damage occurs. Patients in trials will receive more frequent assessments, structured evaluations, and standardized imaging follow-up. Patients may benefit from earlier symptom relief and an improved quality of life. Early recognition of patient readiness requires integrating symptoms, progression, and physiology, not just valve gradients, and the use of AI can assist with this. Thank you.
For our next case, in April of 21, I saw a 76-year-old gentleman who has hypertension, dyslipidemia, asthma, history of DVT, BPH, and osteoarthritis. He had come from his primary care physician with some dyspnea. He has no significant family history of premature coronary disease. He's married 52 years, never smoker, socially drinks and denied drug use, and was on these medications. His exam had a blood pressure of 128 over 70 with a heart rate of 77, respirations of 18. The rest of his exam was pretty benign. He had a 2 out of 6 systolic murmur with no evidence of JVD or pulmonary edema on exam. And his EKG had sinus rhythm at 71 with PACs and nonspecific STT wave changes. He underwent an echocardiogram that here on the left shows in the parasternal view, normal ejection fraction, some thickening and decreased mobility of the aortic valve leaflets shown on the right zoomed. And from the apical 5-chamber view, we can see mild aortic regurgitation. The peak velocity through the aortic valve was 3.5 and the mean gradient was 32. So the whole echo report, again, normal ejection fraction, some LVH, a little bit of diastolic dysfunction. The aortic valve appeared trileaflet, partially mobile, with an aortic valve area that was calculated at 1.5 centimeters squared, peak velocity of 3.5, and a mean gradient of 32 with normal right atrial pressure. And summarizing that in the context of the patient, again, aortic valve area 1.5 with a mean gradient of 32 in a gentleman who's experiencing some dyspnea at high levels of work when he was working in the yard, is the way he described it. he's normotensive and his EKG has normal sinus rhythm. He also had undergone a recent negative stress nuclear for myocardial ischemia. So I'd like to poll you now. How would you classify this patient? Mild aortic stenosis, moderate asymptomatic aortic stenosis, moderate symptomatic aortic stenosis, and severe aortic stenosis. Are you going to get every answer 100% correct here? It looks like. So the question is, and as people are continuing to answer, it certainly seems to me to fit into the moderate aortic stenosis range, but the question is, are the symptoms from the aortic stenosis or not? And I think that's where people are hitting asymptomatic versus symptomatic aortic stenosis. Can you all see the, yes? See if I can make that go away. So what would this trigger in this patient? Should this patient be referred to the heart team for education about aortic stenosis and what to expect in the near future? Should they undergo close surveillance by a primary cardiologist with a recommendation for an echo in a year? Should they be considered for a research or clinical trial, or no need to refer this patient since he's asymptomatic? So I love that there's a nice spread of answers. I think the heart team is pretty busy, and it's harder to take the time to care for these patients in the interim until they become severe, because current guidelines recommend that they have interventions when they become severe. But I would agree with both B and C. The close surveillance should happen with echoes every 1 to 2 years, and this patient should definitely be considered for a clinical trial, as Lexi was describing in her patient. This lovely gentleman came back to us 5 years later. Really, the only differences are that he's now 81 years old. He's much more symptomatic with mild exertion, and he's married 57 years, but his medicines are otherwise unchanged. On his exam, his blood pressure was 160/90, his heart rate was 101, his respirations were 18, and his oxygen saturation remained about 92. His body mass index is 29, and on his exam, he did have that systolic murmur. It didn't seem to be louder than before, but he had a diminished S2 component, no pulmonary edema, and no JBD. His EKG now showed sinus tachycardia at 101 with PACs and nonspecific changes. And he underwent a repeat echocardiogram, which shows normal ejection fraction, some LVH, with thickened aortic valve leaflets on the zoomed image on the right. And then when you watch it move, the leaflets have decreased mobility and the aortic regurgitation appears mild still. When we did his Doppler, it looked much the same through the CW was a peak velocity of 3.5 and a mean gradient of 32. And we put that all together. The ejection fraction was normal with LVH, normal RV function. The aortic valve appeared less mobile. We're assuming it's calcific with mild AI, but his aortic valve area calculated now at 0.9 centimeters squared with a mean gradient of 32 and a peak velocity of 3.5, which were relatively unchanged from his last echo, the gradients. So putting that together, he's much more symptomatic now. His aortic valve area is 0.9, the mean gradient of 32. He's hypertensive and tachycardic, but he has a preserved ejection fraction. So what would this trigger in this patient now? Should he get a TAVR evaluation, or should we do a dobutamine stress echo to sort out the discordant measurements? or should we do a CTA with aortic valve calcium scoring? And I love that there is quite a spread for these answers because there's always no right answer in these very complex patients. TAVR evaluation may be appropriate because the valve area is reduced, but there's something discordant that it'd be nice if we could sort it out first. The stress echo, the dobutamine won't tell us about his functional capacity because we're giving dobutamine, but low dose dobutamine in a normal ejection fraction is a little tricky. It'd be easier for us to look at his CT angiogram with aortic valve calcium scoring, which is what we had done next. And I'll show you his CT scan. On his CT angiogram, you can see aortic valve calcium is heavy with calcifications in the LVOT as well. His aortic valve calcium score was 2200, which Angston units, which is above the threshold consistent with severe. We went ahead and did a cardiac cath, and he had no significant coronary artery stenosis. Managed him a little more closely and repeated an echocardiogram when we had his blood pressure under better control. And what we found was with blood pressure in the normal range, his peak velocity went to 4.4 and his mean gradient went to 44 millimeters of mercury. And helped us see how directly the higher blood pressure was affecting our measurements. So our key takeaways are that the echo assessment of aortic stenosis is quite complex. It relies on good echocardiographic imaging taken in the context of the patient as a whole and any other testing that they might have had. Discordant findings can usually be sorted out by a close look at the echo as well as integrated interpretation with your exam and your other findings. And enrollment in ongoing studies helps us better understand how to diagnose and manage these patients with moderate aortic stenosis.
Thank you, Dr. Kelsey and Lexi, for a wonderful discussion and presentation of such relevant cases. As a reminder, a recording of today's session and the presentation materials will be available in the coming weeks at www.heart.org/moderateas. We have a few questions that have popped up in our chat throughout the session, and I wanted to pose these back to our speakers. So the first question I see is that a participant would like to know if you reach out to a patient or if you reach out to a provider after identifying a patient for a potential clinical trial.
I'll speak for us at Stanford. We primarily reach out to the patient's managing provider, but we really take it on a case-by-case basis because there's some patients who we have identified who have maybe come through the emergency room and don't have a provider. And maybe are referred to cardiology upon discharge, but we've, in that instance, reached out to the patient based off their echo results and offered them an evaluation in our valve clinic. But so really a case-by-case basis, but typically start with the managing provider if they have one.
For us, it's similar. It's related to whether or not the trial is appropriate for the patient. If they're identified, we generally reach out to the provider first. I think it's very important to get the power in the hands of the patients and allow them to see some changed language in their reports because they'll read the reports themselves to make sure they understand that there is something significant happening with their valve. And changing in your reporting habits will help that happen. And then they can approach their provider and get to care quicker.
Thank you. Lexi, a question specifically for you that's come up in the chat is, for the AI echo interpretation being used at Stanford, are you using commercial applications like US2 AI, or have you developed your own AI solutions to analyze raw echo imaging data?
We are using the CardioCare platform by Ignite is our main source. And we pulled a little data from our echo database pack system, but I am primarily using CardioCare, which I find very easy to use.
And at Duke, we're using some home generated AI tools. We've also used Slicer Dicer within Epic. Each has its strengths and limitations and are getting better with time.
Great to hear. Another question that we have in the chat is a participant has asked that if my institution doesn't put SBI on our reports, how can they find this or where would they be able to find this information?
That's a good question. So I think we've also revised our reports recently to make sure that it's not just the stroke volume that's in the report, but the stroke volume index to body surface area. If you look down in the measurement section, it's usually under aortic valve or it's under the LVOT section. You can calculate it if you just calculate the area of the LVOT and multiply by the Doppler, but I would ask them in the Echo Lab to do that for you, right, Lexi?
Yes, I would agree. We also did something similar. Our echo reports back in 2021 just had stroke volume, and all our valve clinic coordinators were manually calculating stroke volume index with the BSA. And we asked our echo lab to start including stroke volume index in their reporting, which we got that change.
Wonderful. And that brings us to the end of our Q&A session. Once again, thank you, Dr. Kelsey and Lexi, for your leadership in this field and for supporting today's educational offering. We are at the top of our hour, and I wanted to also thank our audience for joining us today. This is a second installment of our four-part series, which will be taking place throughout the remainder of this calendar year. Be sure to join us for our next session this summer, which will focus on research readiness and trial infrastructure in medical therapy trials, an area of growing interest in this space. Please scan the QR code here or visit www.heart.org/moderas for a recording of today's session, additional resources, and information on our future sessions. Thank you again for your time today and have a wonderful rest of your day.